taking time for your health. The African American Wellness Watch. Trusted information for us, by us. Dr. Mike LeNoir and other experts from around the country and around the world have the latest on how you and your family can get healthy and stay well. It's time for the African American Wellness Watch.
Good health and welcome to this edition of Black Doctors Speak, the podcast and the Welcome Watch. I'm your host, Dr. Mike LeNoir. This program is sponsored by the African American Wellness Project and the Alpha Gamma Boule Foundation. The situation within our national healthcare system is alarming. It feels chaotic, like watching an unorganized circus. Poor staffing, inexperienced staffing, lack of resources, and zero accountability have left us questioning whether our health is really in safe hands. Lives and well-being are at risk every day because the system is stretched to its breaking point, creating a crisis that can no longer be ignored. To discuss the implication of these changes, when I have a complex discussion on the future of healthcare, I turn to one person, Dr. Mark Smith. Dr. Smith is currently professor of clinical medicine at the University of California, San Francisco. From 2016 through 2019, he co-chaired the guiding committee of the Healthcare Payment Learning and Action Network tasked by CMS to accelerate the adoption of alternative payment models. From 1996 through 2013, he was the founding president of the California Healthcare Foundation, which he led to its formation. Dr. Smith is a nationally recognized health policy expert. He's published over 50 articles in peer-reviewed journals and 25 books, chapters, and monographs. Welcome, Dr. Smith. Thank you very much for taking the time out of your busy schedule. Even though you say you're retired, it appears that you're doing more work now than ever, but I guess that's about to change. Yeah. But let's start with our first. Let me start that again, Mark. All right. Welcome to our program, Dr. Smith. We appreciate you taking the time from what is a very busy schedule to discuss this issue with us. So let's start. You've been on the forefront of some of the most significant advances in healthcare policy and delivery. Can you share how your experience has shaped your views of health equity and the health system reform?
Yeah, well, let's start with health equity. It's a term that's a kind of a loaded term these days, but what we mean by health equity is that everybody should have an equal shot at having a healthy life. And there are some people in this country, in fact, anywhere in the world, who start off with certain disadvantages. You are poorer, you are unable to walk or to see or to hear. You live in an area where there aren't as many resources. You don't have insurance, et cetera. And we know that all these differences make a difference in terms of both the quantity of your life and the quality of your life. So in recent years, there's been, I think, a very good and reasonable effort to focus on trying to identify these areas where there are inequities in the way in which people get health care and try to address them. That notion is under attack now. The current administration has a whole list of words that they don't want to see and don't want to hear, and equity apparently is one of them, along with DEI and underserved and vulnerable and others. But it's clear, and the pandemic made it even clearer if it wasn't clear to everybody, that not everybody gets an equal shot at having a healthy life. And I think it's important for people to keep that in mind as we think about the changes that are happening in the system and the ones that are about to happen.
All right, well, let me ask you this question. How, first of all, whatever impression you have of the way in which these changes are going to happen and implemented, what do you think about the people that have been selected to move this process forward?
Well, they are unconventional at best, and I think in particular Secretary Kennedy has over the years been a pretty vocal advocate of theories that have been quite thoroughly debunked about the relationship between vaccines and autism. We now see a measles outbreak in many states, including here in California. There have already been 2 deaths, and undoubtedly and tragically, I think there will be more. there'll be long-term consequences. And so I think one of the things we all ought to be paying attention to is how some of these leaders, some of whom have been fierce critics of the institutions that they will now be running, how they perform. Let me pick up from here. I also think one of the things that's brewing is changes to the Medicaid program. As you know, Mike, Medicaid, along with its companion program, the Children's Health Insurance Program, the two of them now insure about 79 million people in America, more than Medicaid. In lots of states, the Medicaid program now accounts for a majority of births. And in fact, ironically, there are a lot of states that voted for President Trump where lots and lots of people, including lots and lots of his supporters, get support from the Medicaid program, not only for their medicines, their hospitalization, but mental health services and services for disabled people as well. So the current situation is that the House of Representatives has already passed a bill that implies almost surely dramatic cuts to the Medicaid program. And I think this will have a particular effect on Black and Brown communities, but on Americans from all communities in all states. And we'll have to see exactly how that plays out. But I think many of us are worried that some of the gains of the last several years in terms of improving insurance for people, improving their access to high quality care, is now threatened to be on the chopping block.
Yeah, it's kind of paradoxical because a lot of states that need it the most have not accepted the government's offer to participate in the Medicaid program the way it's been described. So those states, I think, will be even more impacted because they have not done the things that could have been done with the opportunities they had given to them by previous administrations.
Well, yeah, that's true. And also, I think, look, the president has said on several occasions that he would not cut Medicare and would not cut Medicaid benefits. So what you've begun to hear in recent weeks is people saying, well, we're not going to cut benefits. We're just going to cut fraud, waste, and abuse. But there's not $800 billion worth of fraud, waste, and abuse in the Medicaid program. So I think what is likely is that the program will be dramatically cut, and then that bill will be laid to the states to try to pick up the slack in reduced federal payments. So you'll see even greater disparities across the country in terms of access to health care, depending on what state you live in. As you pointed out, there are several very large states like Texas that didn't expand Medicaid when they had the opportunity to do so under the ACA. And so I think it's likely that a year from now, if these changes go through, we'll find even more disparities in America about your access to health insurance based on what state you live in.
What's interesting also about that is that these states have not put in an infrastructure to even take care of the people that they have. And so that's definitely going to be a difference. And so, unfortunately, many of these states have heavy populations of Black and Brown people.
Well, yeah, that's true. But it's also true that some places like West Virginia and Arkansas that have large populations of white people who are dependent on Medicaid are likely to be affected as well. And so I think there's going to be a big battle brewing. In this case, I think hospital administrators, including hospital administrators in deep red states, state legislators that represent poor communities whose constituents depend a lot on Medicaid, I think they will find themselves in a position where they almost have to push back against these changes. And so I'm not smart enough to know how it's all going to turn out. It's clear there will be an effort to reduce Medicaid dramatically. What's not clear is whether or not, or the extent to which that effort will succeed, because I think there are going to be a lot of people who wake up in the morning and realize that the promise of cutting taxes, keeping the first Trump tax cuts and instituting other tax cuts, and doing so in a way that doesn't hurt anybody, and it's all just going to be magically taken out of fraud, waste, and abuse, I think people will wake up and realize that that's actually not mathematically possible.
One of the things that I'm concerned about, I spent the latter part of my career working primarily with Medicaid patients. And so, what am I, as a provider, what do I need to anticipate? And how do I need to make changes? Or how do my plans that cover Medicaid patients need to make changes?
Well, I think that depends a lot on what state you're in. Frankly, if you're in a state that hasn't expanded Medicaid and hasn't been paying much for Medicaid, the changes may not be all that great, I'm afraid. In other places where Medicaid has been expanded and where the federal contribution is significant, I think you're going to have to prepare for dramatic cuts. But I think both physicians, nurses, other clinicians who take care of these populations need to be involved in their professional organizations. I'm sure they'll have a lot to say at state legislators, and need to be involved with civic organizations to the extent that they can help everybody understand the impact of these changes. Look, for a lot of people, if your family hasn't been touched by Medicaid and your neighbors and friends haven't been touched by it, or you don't know it because they haven't told you, it may seem that this is all just kind of complicated politics and pundits and headlines and statistics that don't mean anything. I think one of the responsibilities of people who are involved in healthcare is to make it plain to everybody in their communities what the impact of these cuts are, and help people understand that though you may not know it, your neighbor's child or your aunt or some other person that you may not have known was on Medicaid, in part because it has a different name. Medicaid often has a state name. So in California, it's Medi-Cal. And I'll bet a lot of people don't understand that Medi-Cal is this Medicaid program we're talking about cutting. So in Ohio, it's something else, and in Tennessee, it's something else. So I think one of the responsibilities of professionals who are involved with these populations is to make sure that everybody knows this program that people rely on and like is the same thing that they're saying they want to cut with the other on the other side of the table.
Speak to us a minute on how the healthcare of the least of us impacts the healthcare of the most of us.
Well, I can think of several ways. Aside from the humanitarian issue, the issue of our being our neighbor's, our brother's keeper, if I don't have health insurance and I break my leg, I'm still going to seek care for my broken leg. If I don't have health insurance and I have COVID or a heart attack, I'm still going to seek care for COVID or heart attack. That means I'm going to go either to some place that's in the charity system, the safety net system, or if it's an emergency, to the emergency room, for which all of us eventually pay. So to the extent that there are people who are able to get care earlier, more conveniently, less expensively, when conditions can be treated better, if those conditions linger, if they get worse, if they become dramatic or emergent, they will eventually be cared for in more expensive places, and those more expensive places will be paid for by all of us, either because we're paying for the emergency room or because the emergency room and its associated hospitals will seek to increase what they get paid by employer-based health insurance in order to cover the payment that they're no longer getting for their uninsured patients. And so in many ways, part of the role of health insurance is to spread these costs out, to try to encourage and give people the opportunity and the incentive to seek care earlier. And when they seek care later, in many, not all, but in many instances, that care winds up costing more. And that higher cost is cost that we all pay for in one way or another.
Yeah, you know what's puzzling to me? Well, not puzzling. I think we've talked about this before. You and I understood that health equity and the focus on health equity in this country would come to an end at some point. And most of the people don't remember the name of the individual that started this whole march to health equity. We've actually been to the pinnacle in many ways, in the sense that what we've done here in California and other places is we have funded the Medicaid program to include aspects of health equity like social determinants of health. It's clear to me that those budgets, once they're cut, this will be one of the first pinnacles of those changes in Medicaid that we've made progressively. And that whole issue and focus on social determinants of health may completely disappear.
Well, they may. And frankly, I think much of this is not economically driven. It's kind of ideologically driven. It's part of a retrenchment, kind of the end of Reconstruction. When you take a military base whose name had been changed from that of a former Confederate general to something like Liberty, and then the defense secretary has changed it back to Fort Bragg, not the original Confederate Fort Bragg, but some other hitherto unknown soldier whose name happened to be Bragg. That's not an economic decision. That's an ideological decision. And so much of what we see now seems to be kind of a very intentional desire to attack and to roll back some of the very progress that you're talking about. At the same time, I have to say that I don't think the fight for health equity is by any means dead, not just because administrations come and go, but because there's been now 30 years of growing evidence that I think is widely accepted by people in healthcare, that there's lots of stuff in healthcare that wouldn't have to be spent if we tackled the problems of people's nutrition, of people's transportation, of people's education, access to food, etc. And to the extent that we hold healthcare institutions responsible for the actual health of a population enrolled with them, they'll continue to have a self-interest in paying attention to those aspects of social determinants that really affect people's seeking care. So if I'm going to have to pay for the health care of my enrolled population, if I'm, say, Kaiser Permanente or any one of a number of other capitated organizations, it's going to be in my interest to make sure they have transportation to keep their appointments, that they have the capacity to eat the right food, et cetera. So I'm hopeful that some of the changes that are going on in the way providers are paid can kind of hardwire and institutionalize our consciousness, at least, about social determinants, even if some of the programs that are going to be rolled back in the next year or two are in fact rolled back.
Well, yeah, I think that's a very optimistic point of view. I've always felt that the health equity, the movement toward health equity would end because it really has no organized supporter. I mean, you would expect that the opposition party would be the party to advance the purpose of health equity and its implementation. But they seem more disorganized than we're having in this conversation about Medicaid. They do not seem to be an effective advocate. And without them in your corner, and with all of the health educational institutions and various social media bending the knee to the present administration, I just don't see where this going. Where is this impetus to move health equity forward coming from?
Well, I'm going to try to be optimistic despite being worried, in part because, look, a lot of these people aren't even in their seats yet. So I think today is Tuesday, the 25th of March, as we tape this. And Dr. Oz, I think, has been confirmed by the Senate. So I don't want to presume what he's going to do. He certainly understands a lot of these issues. So let's give it a little bit of time to see just how some of this shakes out. I won't presume that everyone in the incoming administration, particularly those who are experienced professionals who are going to be in charge of some of these health organizations, share the same personal animus that some senior people in the administration, including the president, seem to have around these issues. And I'm optimistic, I'll try to be optimistic, that the clear, obvious science and self-interest of health providers themselves in continuing to pay attention to those aspects of social determinants that improve people's health and improve the affordability of healthcare in the long run will continue to be supported and focused on. At least that's my hope.
Finally, one final question. Obviously, you never like to end a discussion like this without an individual or collective call to action. I'm a physician in the waning stages of my career. I seem to extend it a little bit
Michael,
longer.
you are just ascending the pinnacle of your career. I don't want to hear this waning stages stuff.
Well, yeah. Well, let me just say it this way then. I want to know, what can I do? What can the individual do in order to advance the cause of health equity? And what happened to those discussions we used to have about single payer and Medicare for all? Is that kind of a discussion that's gone forever?
No, I don't think it's a discussion that's gone forever. It's a discussion that's been going on for at least 50 years. And I think in some ways, the provocation of millions of Americans losing health insurance and the consequences to themselves and their families may, in fact, reignite this discussion in ways that we can't predict now. So, single payer, Medicare for all, there are a variety of slogans that have been used to describe different approaches to universal health care. But my sense is it is entirely possible. Look, history swings in pendula, right? So the pendulum has swung clearly in one direction for the time being, but the unintended consequence, perhaps, of an all-out assault on the underpinnings of care for low-income people may lead to a reignition of people's consciousness, including that of people who really didn't think about this before because they didn't have to, because those supports were in place. It may well lead to a reignition of consciousness about trying to rid our status of the only advanced country that doesn't have universal care. As to what you can do, Michael, what you can do is keep doing what you're doing, which is kind of sending out the clarion call. I think all of us need to be involved both in our professional organizations' activities to lobby for good stuff and against bad stuff, and to help the public understand what is happening. Look, people's attention is drawn on by so many things these days. There's social media and March Madness, and people's attention kind of tends to wander. So it'll be important that in the midst of a flurry of misinformation, disinformation, euphemisms, and sleight of hand, that when there are real consequences, when kids in our communities are getting measles, when disabled people in our communities are not able to access services upon which they depend, when people wind up in the ER rather than in the doctor's office unnecessarily because something wasn't done early, it'll be important for those of us who are in a position to point that out, to continue to point it out in order to try to help break through the flurry of puff that's going to go on around all these issues.
Well, Dr. Marks, as usual, you bring a lot of clarity to these very complicated health issues. I think people can better understand now what they're facing and maybe have some idea how they're engaged, regardless of what their insurance looks like now. One of the things we didn't talk about, and maybe in our next conversation in a month or so, when we see what's happening, is the fact that when Medicare and Medicaid reduce services, so do private insurance companies reduce services. So I think we're all kind of connected in that. And I thank you for your taking the time, and your clarity on these issues is really quite remarkable. And so we'll keep talking to you as we see this evolve, as we see these conspiracy theories roll out or roll under, as we see Dr. Oz try to deal with something other than a TV script. And as I don't even know the new CDC director who she is. But in any event, I think we're in for a rough ride for at least a few minutes of time. So thank you so much for joining us.
My pleasure. Keep doing what you're doing.
Just stay where you are. I'm ending the recording.